everyone, and welcome to this discussion on the recall questions of NEET PG 2023 anatomy part. I am Dr. Ashwini Kumar. I'm a faculty of human anatomy at Dr. Bhatia Medical Institute. Well, before we start with these questions, let's have a little analysis about the exam, that how the exam was and what direction we are moving towards based on the questions which were asked in the exam. If I just talk about the anatomy part and the integrated anatomy part, we are basically moving toward the era where the questions are going to be like 90% questions are going to be clinically oriented. So when you look at the core anatomy questions, there were very few, but there were clinical anatomy questions for which you don't need to have a detailed clinical knowledge. If you just have a basic knowledge of anatomy, you are still able to solve those questions here, which is again an emphasis that knowing the preclinical and paraclinical subject is going to be really important in future as well. So you need to have that mindset that people who are preparing for the next exam also, the subjects for the first year and second year are they really going to make a difference. So as I said, this video is purely based on the recall. So there are questions which you may find some variation in the language, you may find some variations in the pictures, and you may see the variation in the options also, which is always subject to discussion. You can always put your comments in the comment box, and we'll try to incorporate those changes. But see, the main motive for this recall video is because when the INI-CT exam is approaching again in a couple of months only. And we know that when you have both INI-CT and NEET exam are both more of a clinically oriented exam nowadays. So it's very important to know that what is being asked in the recent exam. Thankfully, the one-shot video which I recorded and in fact did live on YouTube was a huge success, all thanks to you people. And many information we discussed in the one-shot video was asked in this exam here, which is basically it is an indication that nothing changes. What basically is changing is the way they are asking those questions. The same core anatomy questions are now clinically oriented, and they are put together with other subjects, and they are giving it to you here. So understanding the anatomy, the core anatomy, and the clinical of that particular structure is what utmost important here. Now, based on the recall that I'm going to make here, guys, I'm going to discuss around 17 questions with you, but I can take it to the 2021 questions. There are around 21 questions in which the anatomy was really helpful. But I'm not going to discuss all these questions from you, like a couple of questions from the ophtha, like about the homonymous hemianopia. There was a question on the basal ganglia about the rigidity and all. So that will be discussed in the physiology part and ophtha part. So I'm going to go with the 17 questions in here. And just to quickly analyze these 17 questions, what I saw that there were 3 embryology questions, again clinical embryology questions, like 2 of them. Head and neck questions, 5 questions were there from the head, neck and face. And the neuroanatomy questions, there are 2 neuroanat or clinical neuroanatomy questions were there. 1 question from upper limb, 1 from lower limb, 1 histoimage, and 1 question is from the 4 questions from abdo and pelvis here. That counts around 17 questions in total, which I always say in my regular class also, that head and neck, neuro and embryology, like this generally comprises of the 50% of paper itself here. That's why you must have, the people who attended my class, they know that I start with head, neck, face, then neuroanatomy, then embryology. That's the sequence I follow, and I always say that these first 2-3 days are the most important because maximum questions will be asked from this area here. So guys, without a further ado, let's get on with the questions here. So I'm going to start with the questions of embryology itself first. So moving on to the question number 1. Well guys, the question number 1 says that a 30-year-old male patient presented with the midline swelling which moved with the tongue protrusion. What is the likely diagnosis here? Now the first thing is, it says the tongue protrusion. The swelling is there, it's a midline swelling that you can see, and this midline swelling, it moves with the protrusion. The tongue with tongue protrusion, and that's the biggest hint in this question here. The patient comes to you with a midline swelling of the neck or any neck swelling, the differential becomes very important here. So the first thing we generally do is we differentiate between the thyroid and non-thyroid swelling by asking the patient to swallow, right? We know that thyroid swelling, they move with the swelling, and non-thyroid swelling, they do not. So before we get to the answer to these questions here, let's have a very quick discussion on the development of the thyroid gland, and that will take us to the exact answer to this question here. So what do you see, guys, in the thyroid gland development? Now there is, when you look at the pharyngeal arches, when you look at the inner aspect of the pharyngeal arches, when the pharyngeal arches are fusing with each other, the junction of the first and second arch, just caudal to the tuberculum impar, there is a foramen, there is a blind diverticulum present. That's endodermal diverticulum is called as a foramen cecum. Now this is where the foramen cecum is shown in this picture here. Now foramen cecum, first of all, is the one which is present at the junction of the first and the second arch, and it is present just caudal to the tuberculum impar. Now from this foramen cecum, this thyroid diverticulum will form, and this thyroid diverticulum will keep on growing downward, as you can see in the next picture here. Eventually, in the 5th week, in the later 4th week and the 5th week, you will see that this thyroid diverticulum will divide into the thyroid lobes, the primitive thyroid lobes, and eventually the thyroid lobes will keep on descending downward. Once they reach their final position, the duct which is connecting it, called the thyroglossal duct, will involute. Look at this picture here. You can see the thyroid lobes are being developed here, and there is a thyroglossal duct breaks down here. The thyroglossal duct breaks down. Usually the thyroglossal duct disappears, but you may or may not have the remnants of the thyroglossal duct here. Now, sometimes you will see the proximal part of the thyroglossal duct. The proximal part of the thyroglossal duct, it remains as a foramen cecum only. You all know that the junction of the anterior 2/3 and posterior 1/3 of tongue, there is a foramen cecum, which is basically the proximal part of this thyroglossal duct itself. It's an indication from where the thyroid gland starts developing. And the caudal part, or you can say the distal part of the thyroglossal duct, this portion here, the distal part of the thyroglossal duct, it may persist in the form of a pyramidal lobe. You must have seen that thyroid gland is connected by the isthmus, and the isthmus, you will see an additional glandular tissue there called as a pyramidal lobe, and that pyramidal lobe is again formed from the thyroglossal duct, the lower part of thyroglossal duct here, right? So thyroglosal duct remnants are there. We have a normal remnants like the pyramidal lobe is made up of thyroglossal duct, and we can have the proximal part, we said it persists in the form of a foramen cecum. But if you look at the entire migratory pathway of the thyroid gland here, now have a look at this picture, guys. If you look at the thyroid gland migratory pathway, it's starting from the junction of the anterior 2/3 and posterior 1/3 of tongue, and that's the final position of thyroid gland. Now look at these side, you may have the remnant of this thyroglossal duct, and those are called as thyroglossal cyst. So you can have a thyroglossal cyst present in the tongue. You can have a thyroglossal cyst present above and in front of the hyoid. You can have thyroglossal cyst above, in front and below the hyoid, or you can see the thyroglossal cyst present in front of the thyroid cartilage. Now this thyroglossal cyst, it moves up with the tongue protrusion via the thyroid descent, via the remains of the thyroid descent here. Now if let's say there is a cyst present somewhere here in the midline of the neck, and that is connected to the foramen cecum by the remains of that thyroglossal duct. So every time the person will protrude the tongue, this will also be pulled up here. And that's what the question is indicating here, that there is a midline swelling in the neck, and that moves with the tongue protrusion. As I said, the tongue protrusion is the biggest hint there, which tells you it is the thyroglossal cyst. That's a thyroglossal cyst, and these midline neck swelling, the thyroglossal cyst, they move with the tongue protrusion here as they're connected to the tongue by the remains of thyroglossal duct here. So from the question's point of view, the answer here is a thyroglossal cyst. Now all these other options, which may or may not, there could be variation in the options also, but let's say if the options were the one which is based on the recall again, the ranula, the branchial cyst or dermoids, now they are not the answer to these questions here. If I just show you one image here again, now look at this picture here, guys. This is a picture showing the ranula. Now you all know that ranula basically is present in the floor of the mouth. This is basically present in the floor of the mouth. You can see this bluish tinge in this ranula part, and it is because of the during the development of the salivary. Because of the blocked salivary gland. I can say it is because of the blocked salivary gland. Right? Branchial cyst, guys. Branchial cyst. You all know about the branchial cyst. The branchial cyst is basically the persistent cervical sinus. The persistent cervical sinus, if the part of the cervical sinus persists, then you can see a swelling along the sternocleidomastoid here, usually harmless. That is called as a branchial cyst. So this branchial cyst is because of the persistence of cervical sinus. So anyways, it's not a midline swelling. Okay. And then we have another thing which may look like a midline swelling, and that could be one of the dermoid cyst in the neck. Now, dermoid cyst could be anywhere, but if the dermoid cyst, let's say this here is the dermoid cyst present in the neck. Now, dermoid cyst is because of when the skin layers, they do not grow properly, so you can have this dermoid cyst here. But again, these dermoid cysts are not connected to any deeper structures inside, so they don't move with the deglutition here. And that was the hint in this question here, that the swelling actually moved with the protrusion of the tongue, and that's why the answer to that question is the thyroglossal cyst and not the ranula or branchial cyst or the dermoid cyst. Which takes us to our question number 2. Now, the second question here was something like this, that which of the following is the remnant of the marked structure here, guys? Now, there's a picture which I again always discuss in my class here. That's a picture showing the craniocaudal folding of the embryo. And in the craniocaudal folding of the embryo, what you will see, this is the head end of the embryo here. And this in here is the tail end of the embryo. And what you can see at the head end of the embryo, you will have the oropharyngeal membrane will be there. There will be septum transversum, the cardiogenic area. And toward the caudal end of the embryo, now what you see, guys, this is the hindgut area. This is what the future hindgut will be. And from the hindgut region, you can see an extension coming out from there, which is called as the allantois. That endodermal diverticulum here is an allantois. This is a yolk sac. Now you know that when the primary yolk sac converts into the secondary yolk sac, the yolk sac gets impinged. A part of the yolk sac is taken away. Similarly, again, when the craniocaudal folding and the lateral folding of the embryo will take place, again the part of the yolk sac will be pinched away. And that will be connected with the remaining gut tube by the duct called as a vitellointestinal duct. So this here is a vitellointestinal duct here, and this extension here, which is toward the caudal end of the embryo, is the allantois. And the question was, with the marked structure, actually, basically I didn't mark it here, the marked structure here was the allantois here. The marked structure they asked was the allantois. So as per the recall, as per the feedback, it was the allantois they put the arrow on, and the question was that what is the remnant of this marked structure here. So this allantois in certain lower animals, like in birds, it acts as the entire bladder only. Now in human, if you look at this allantois, guys, if let's say this is the hindgut here, and here is the allantois, this diverticulum. Now the basal part of this allantois, this is the hindgut here, the basal part of the allantois will get absorbed in the formation of the urinary bladder only. Whereas the distal part of this allantois, will get fibrosed and will give rise to the urachus. And this urachus will persist as one of the ligament of the urinary bladder called as the median umbilical ligament here. Median umbilical ligament. The remnant of the urachus will be the median umbilical ligament. Remember, it's median, not medial. So the answer to this question is option C, that is a median umbilical ligament. But let's talk about the other options also. Like option A says medial umbilical ligament, the lateral umbilical ligament, or ligamentum teres. If let's say these were the exact options, or there could be variation in these. Now, when you look at the anterior abdominal wall from the posterior side, you're looking at the anterior abdominal wall, but from the posterior side. This is how it's going to look like here. Have a look at this picture, guys. You're looking at the anterior abdominal wall, but that's a view from the posterior side. So you can see this fascia over there is a fascia transversalis, right? That's a fascia transversalis over there. Now, can you see the urinary bladder there? Now, here's the urinary bladder, and look at this ligament which is reaching the level of umbilicus. This is what is called as a median N, the one which we just talked about. That's a median umbilical ligament, which we just said is a remnant of the urachus, or you can say allantois. Just lateral to that, we have a pair of medial umbilical ligament. The pair of medial umbilical ligament, which is a remnant of the umbilical artery, guys. A part of the umbilical artery, the proximal part of the umbilical artery, is basically utilized to form the superior vesicular artery, one of the artery of the bladder only. And the distal part of the umbilical artery will persist in the form of this ligament called as a medial umbilical ligament. Medial, make sure you are reading it right. Median and medial umbilical ligament here, which is a remnant of distal part of umbilical artery. And furthermore laterally, if you see furthermore laterally here, you can see another fold there, guys. This fold here is called as, again, we have a pair of this. We have a lateral umbilical fold, and this lateral umbilical fold is present on the, it's a fold which is present on over the, it's a fold present over the inferior epigastric artery. Fold over the inferior epigastric artery. See, the reason to go into a little more detail of these questions is because, you know, these topics were asked in the previous year exam also. These topics are asked now as well, and these questions will be asked in the future as well. The only thing is they will just keep on changing the language of questions. Sometimes they'll make it clinical, sometimes they'll just make it maybe an image-based question or something here. But you know, the core concept will never change here. If you know about the core concept, if you know that how these ligaments are formed and what these folds are, you can always answer those questions without any difficulty here. So this time it was about the allantois, which was marked in the craniocaudal folding of the embryo image was given, and the answer is a median umbilical ligament. But let's say if there was a medial umbilical ligament, you will say it's a remnant of the umbilical artery. If it's a lateral umbilical fold, it's a fold which is present over the inferior epigastric artery here. Now, we also saw the vitello-intestinal duct over there, guys. Look at that. We also saw the vitello-intestinal duct. Now, maybe next time they will give you this picture and they'll put an arrow on the vitello-intestinal duct here. So, one of the remnant of the vitello-intestinal duct is called as a Meckel's diverticulum. I'm sure everyone read about the Meckel's diverticulum. Here is a picture of a Meckel's diverticulum that you see here. So, Meckel's diverticulum is basically, it's a true diverticulum. It does have all the three layers basically. So, this Meckel's diverticulum is the remnant of the vitello-intestinal duct. The vitello-intestinal duct here. It's the most common congenital anomaly of the GI tract, the Meckel's diverticulum, the very, very commonly found structure on the anti-mesenteric border of the small intestine. And if I go with the options, the ligamentum teres was also there in the option which I'm showing here. The ligamentum teres, as we know, that it is present in the lower part of falciform ligament. Here is a falciform ligament which is basically dividing the liver into the two anatomical lobes, right and the left lobe here. And in the lower part, you can see this ligament present over there that is called as a ligamentum teres. And what exactly ligamentum teres is? It is basically obliterated left umbilical vein. It is obliterated left umbilical vein. The ligamentum teres is an obliterated left umbilical vein. This is, see, in last couple of years, this is what we are seeing, that they're giving the questions like these. Last year NEET exam, they gave a picture of a falciform ligament. I mean, there was a question about the development of falciform ligament coming from ventral mesogastrium. That was an image-based question here. This time, it was a question on the allantois. So you need to keep in mind here that this is the trend here. This is what they're asking. They're giving that image-based question on the maybe a general embryology or the systemic embryology here, and they're asking a very basic question only. They're not going to ask you something very detailed in it here. It's a very basic question. So all you need to know is you just need to identify the structures. Like you must have seen that the same is with the questions of the neuroanatomy questions also. All the three sections, the coronal, the transverse, the sagittal section, it's imperative to understand and identify the structures, because the questions related to them are pretty simple here. But if you don't know, if you cannot identify what is fornix, how mammillary body looks like here, the question goes into vain here. So it's very important, the identification of the basic structures in the real-time section, or even if it is a schematic line diagram, is very, very important here. So guys, yes, for this question here, the question number 2, the answer is a median umbilical ligament here. Chali, moving on to the next question, the third question, which is again the question from embryology, the clinical question again here. Now again, this question again is an indication that how important pharyngeal arches are. Even in my regular classes also, the people who attended my class, they know that I always emphasize that in the embryology, in the current scenario, looking at the last 3-4 years, the pharyngeal arches and anything related to pharyngeal arches is important. They have asked the question about the nerves of the pharyngeal arches, which is basically one of the questions that where the nerves of the pharyngeal arches were developing from. Then the questions about the pharyngeal arch derivative, there's always a question here. The question about the absent thymus and, you know, hyperparathyroidism, the third pouch anomaly questions here. There's a question on the branchial cyst. There's a question on this, the patent ductus arterius. The last INI exam, there was a question in which you have to match the pharyngeal arches with the respective blood vessels, arteries. So pharyngeal arches is a very hotshot topic nowadays. So again, for the people who are going to appear for the upcoming INI-CT exam, make sure in the embryology, you give a special emphasis to the pharyngeal arches. Now, what you see in this picture, question number 3 says, which of the following aortic arch is responsible for the given anomaly in this picture, guys? Now, what is the anomaly in this picture? I'm pretty sure anyone can identify that. You can see there is a pulmonary trunk there, and it is connected directly to the arch of aorta. And that obviously is the case of the patent ductus arteriosus. It's the case of PDA, the patent ductus arteriosus. So to understand the patent ductus arteriosus, first we need to know that how the ductus arteriosus was formed and what exactly it is a remnant of. Now, let me take you to a picture where you can see the pharyngeal arches. I'm pretty sure that all of you are oriented to this image here. You're looking at this. That's initial part here is basically the cranial end of the heart tube, which is the we have the truncus arteriosus, which will divide into the ascending aorta and pulmonary trunk. We have the two dorsal aorta, guys. We have this right dorsal aorta. Look at this, my pointer here. That's a right dorsal aorta. And here we have a left dorsal aorta. And eventually both right and left dorsal aorta, they will fuse to form a common aorta only in the lower part. And this cranial end of the heart tube, that is the truncus arteriosus, is connected to these dorsal aorta by the means of 6 pharyngeal arch arteries. We have 6 pharyngeal arches, so obviously every pharyngeal arch is having artery, and the job of that artery is to connect the the cranial end of the heart tube to the dorsal aorta. So you can see the first, second, third, fourth, and the sixth. The fifth arch, they did not draw it here because the fifth arch disappears here. So ignore the fifth one here. So we have 1, 2, 3, 4, and directly the sixth one here. The first arch artery, the remnant of the first arch artery is the maxillary artery. The remnant of first arch artery is maxillary artery. It's the remnant only. The remnant of the second arch artery is the stapedial and hyoid artery. Stapedial and hyoid. Third arch artery gives rise to common carotid, and that will be seen continuing as the internal carotid artery. So common carotid and internal carotid artery are the derivative of third arch artery. Both right side and left side I'm talking about here. And there comes an important fourth arch, guys. Fourth arch artery on the left side will contribute to the arch of aorta. Fourth arch artery on the left side will contribute in the formation of arch of aorta. Whereas the fourth arch artery on the left side forms the arch of aorta, and the fourth arch artery on the right side will forms the right subclavian artery. I'm writing RSA, that is right subclavian artery. So the normal and abnormal right subclavian artery is also one of the questions asked in the previous year exam. So left side fourth arch artery, arch of aorta, contributes to arch of aorta, and the right side fourth arch artery, it contributes to the formation of the right subclavian artery. Fifth arch disappears, so there's no question to discuss that. Now we have a sixth arch. The proximal part of the sixth arch artery will contribute to the formation of pulmonary artery. As you can see the PA written over there, that is for the pulmonary artery, which will go into the developing lung buds. So pulmonary arteries are formed by the proximal part of the sixth arch artery, and which brings us to our main point here. The distal part of the right sixth arch artery, look at the one which I'm pointing at right now. The distal part of the right sixth arch artery, it disappears. It disappears. It vanishes. But that is not the case on the left side. On the left side, the distal part of the left sixth arch artery will persist in the form of the ductus arteriosus. The form of the ductus arteriosus. Ductus arteriosus obviously after birth will close and will become ligamentum arteriosum. Now that's the normal remnant here. But let's say if the ductus arteriosus fails to close, that will give rise to the patent ductus arteriosus. So patent ductus arteriosus is formed by what? It is formed by the distal part of the left sixth arch artery. Distal part of the left sixth arch artery. Even if they ask you to mark it more precisely, the proximal and distal. Although based on the recall, it was said that in the question it was not the distal and proximal. They simply said that the PDA, the patent ductus arteriosus, is because of what? And the answer obviously has to be the remnant of the left sixth arch artery. More precisely, the distal part of the left sixth arch artery is the answer to this question number 3. You can see there's another picture. I just kept this picture to show how the PDA will look like if it is a cadaveric image based questionnaire. You can see the arch of aorta, the pulmonary trunk, and you can see this connection over there. That's the patent ductus arteriosus. Chali guys, moving on to the next question. Well, when I saw this question asked in the exam, I kind of laughed to myself, because this is a kind of joke which I usually crack in my class also, that generally when I'm teaching, so this in the head and neck, the portion about the TNJ is usually post lunch, like according to my classes, it usually comes in the post lunch part. And I always say that in the post lunch sessions are a little, they're a little lethargic. So you should not yawn too much in the class, otherwise your jaw may get stuck in the open mouth position only, because the anterior dislocation, the most common dislocation of the TMJ. And when I saw this question was asked, so I kind of recalled that when every time I say this, the medical student got his jaw stuck after the wide yawning, well, which is very much possible, as I said, in the post-lunch session especially. So which muscle is attached to the articular disc? We'll go into the spasm here. Now, first of all, guys, it says that medical student got his jaw stuck after wide yawning. Wide yawning means a depression of the jaw, that is opening of the mouth. And the only muscle of mastication out of these four, which is responsible for the muscle of for muscle of mastication, which is responsible for the depression or the opening of mouth, is lateral pterygoid. Now, first, I want to show you this picture here. Look at this picture. This is a picture which is showing you the anterior dislocation of TMJ. Now, normally, this here is the mandibular fossa. Now, as you can see, this is the mandibular fossa. This is where the head of the mandible is supposed to be. But because of the excessive depression of the mandible, what happens is the head of the mandible is shifted from this mandibular fossa in front of this articular tubercle. Now, that's the only small bony support that we have in front of the head of the mandible, which is called as the articular tubercle here. And once the head of the mandible gets stuck in front of the articular tubercle, now it becomes like virtually impossible to close the mouth again here, unless you just depress this head here, push it back into the mandibular fossa, and then only the closing of mouth is possible here. So this is the most common dislocation of TMJ, the anterior dislocation here, which is caused by the excessive opening of mouth here, and opening of mouth is done by the lateral pterygoid here. But there's another hint in the question. It says the muscle which is attached to the articular disc. The only muscle which is attached to the articular disc. Look at this image here. Now, what is articular disc? It's a fibrocartilage. You can see that inside the joint cavity of the TMJ, this here is the articular disc, and this articular disc is a fibrocartilage. It's a fibrocartilage, and this is considered as the extension of tendon of the lateral pterygoid muscle. Now, the muscle that you're looking at right now here, we have upper head and lower head of this muscle. This muscle here is lateral pterygoid. This muscle is lateral pterygoid, and you can see this muscle is like running backward. The origin is from the lateral surface of lateral pterygoid plate, and then it is going backward, inserting on the capsule of TMJ, and also to the pterygoid fovea, which is a small depression present in front of the neck of mandible on the pterygoid fovea and on the capsule of the TMJ. And it is believed that this articular disc or this fibrocartilage is basically the remnant of or extension of tendon of lateral pterygoid only, is an extension of lateral pterygoid tendon itself. So, from that point of view, the question is pretty simple here. It says that which muscle is attached to the articular disc. Even if they have not given this, the clinical case here, they could ask this question simply also, that which muscle is attached to the articular disc of TMJ. The answer will not change, and the answer is the lateral pterygoid muscle. In my classes, also in my one-shot video, I've also discussed that how to differentiate between the muscle of mastication. I always say this, that in head and neck, though we have so many important topics here, but for some reason, and this like goes back almost a decade, that muscle of mastication is, for some reason is always one of the very, very important topic here. The only movable joint here is a TMJ only, guys. That's why it's kind of, the questions are asked very, very frequently on this. And you will also notice that lateral pterygoid for some reason is their favorite muscle here. When you look at the previous year question, once there was a question on the temporalis muscle. Otherwise, when I recall the questions of the previous year, almost every time the question they asked, the answer is a lateral pterygoid. Maybe the question on the identification, on the action, or this time it is about the anterior dislocation here. In this question, also remember one thing, guys, that they may also ask this question, that spasmodic contraction of which muscle is required for the reduction of this dislocation. Now, if you want to reduce the anterior dislocation is basically in the depression of the mandible, and now the head has gone forward. So basically the entire mandible is protruded. So we need a muscle which can retract the mandible back here. So when you put your thumb on the molars and you push the mandible down, which muscle will help to pull the mandible back into the mandibular fossa? And the only muscle which causes the retraction is the temporalis muscle. So this is like one step forward again here. Lateral pterygoid muscle is the one which may undergo the spasm when there is anterior dislocation here. But there is also the muscle which is stretched here, that is a temporalis muscle, the muscle which basically will pull the mandible back. So when we try to reduce the anterior dislocation of TMJ, then the muscle which pulls the mandible back into the mandibular fossa is the temporalis muscle, and that is the only muscle for the retraction here. None of these four muscles can do the retraction. Temporalis, unique action. Temporalis is responsible for elevation and retraction. And in this case, if the question is asked that which muscle will help to pull the mandible back into the mandibular fossa, the answer has to be the temporalis. But for this question, yes, the answer is lateral pterygoid. The answer is lateral pterygoid. Now, moving on to the next question, guys. The next question here, question number 5. Basically, it's a endoscopic view of the nasopharynx which was given here, and the question was simply about the identification here. So that's why I've included this question in here. So it's not any clinical question, something. It is simply about the identification of the structures here. Now, when you put this the nasal endoscope inside, so what you'll see, there are certain structures which need to be identified. Now, first, to identify that what exactly the arrow is pointed on, I wanted to show you one anatomical picture of the lateral wall of the nose. So when you look at this picture of the lateral wall of the nose, there are certain important structures that you need to identify. Let's say here is this is the direction the endoscope is entering here. Now, once you cross this inferior nasal concha, guys, once you cross this inferior nasal concha here, you're basically reaching toward this nasopharynx area here. Now, what you will see in there, first of all, there is an opening of this eustachian tube. Now, as you can see, there is an opening of the eustachian tube. So, there's an auditory tube opening over there. And what you'll see, that auditory tube opening, it is surrounded by this elevation here. And this elevation is called as a torus tubericus. The tubal tonsils are present over there, right? Now, what you see, that we have a fold which is present in front of it. I hope you can appreciate that fold over there. And there's a fold which is present behind this opening of auditory tube. The fold which is present in front here, this fold here is called as a salpingo-palatine fold, guys. This fold is called a salpingo-palatine fold. It is basically coming from the salpinx, that is the opening of the eustachian tube, and it is coming toward the palate here. So here is a salpingo-palatine fold. The salpingo-palatine fold, and this mucosal fold, the salpingo-palatine fold, is basically holding what muscle? Levator velli palatini muscle inside. If you remove the mucosa over there, you'll find a muscle deep to it. That muscle is a levator velli palatini. Levator velli palatini. Remember that. And then you can see a fold which is posteriorly to the eustachian tube, and that fold is going toward the pharynx. This fold here is called as salpingo-pharyngeal fold. That is a salpingo-pharyngeal fold. And deep to this salpingo-pharyngeal fold, we have a muscle with the same name only. The muscle is salpingopharyngeus. That muscle is salpingopharyngeus muscle, the salpingopharyngeus muscle. And if I go further backward, in the same endoscopic view, if I go further backward, then you will see this space here, guys. This space here basically is called as a pharyngeal recess. This is called as a pharyngeal recess, or also called as fossa of Rosenmuller. The fossa of Rosenmuller. So basically, when the endoscope, like when you have this endoscopic view, once you pass this inferior nasal concha, now these are the things that you will notice here. First, you will see the salpingo-palatine fold. After that, you have the opening for the eustachian tube. After that, you have a salpingo-pharyngeal fold, which is having a salpingopharyngeus muscle. And then finally, you have this recess called as a pharyngeal recess or fossa of Rosenmuller. As per the recall, they said that arrow was put something like this here. So that's a view when you go from the anterior side, guys. There has to be this salpingo-palatine fold in the front here. Then we have this opening present here. That is an opening for the auditory tube. The eustachian tube opening is there. Then you have this fold which is present. We are going from anterior to posterior, guys. That's a more posterior fold. That is the salpingo-palatine fold. Salpingo-palatine fold here, which is having a salpingopharyngeus muscle. Like in this is the torus part here, and then we have the recess where the arrow is pointed here, and this space here is nothing but the fossa of Rosenmuller. So answer to this question is the fossa of Rosenmuller here. It was not a clinical question. It was an endoscopic view of the nasal cavity. It was simply asking the anatomical space or the landmark there, and that is nothing but the fossa of Rosenmuller. The adenoids would be like a little more posterior. If I just show you this picture here, the adenoids will be here. This is where you will see the adenoids present. So it's basically about that identifying that where the arrows, like some people said that arrow was actually placed on this tubal tonsil area. And most of the people actually advocated that the arrow was kept behind this salpingo, the pharyngeus fold, and it has to be the fossa of Rosenmuller in this question. Now moving on to the next question, guys. The next question, question number 6, it says a child has tonsillitis and the pain is referred to the ear. Which of the following nerve is responsible for it? A very, very common question here. Like it's a question which I'm sure everyone would have marked this answer right only here. Now, as you know, the glossopharyngeal nerve, guys, the glossopharyngeal nerve is responsible for carrying the general sensation and the taste sensation from posterior 1/3 of tongue. It also carries a sensation from the palatine tonsil and even from the soft palate also. That the posterior area, the posterior 1/3 of tongue, the palatine tonsil, the mucosa over the palatine tonsil and soft palate, that's the area basically of the what do you say, of the glossopharyngeal nerve. And then we have the tympanic branch, or you can say Jacobson's nerve, which is also a branch of glossopharyngeal nerve, which is carrying the secretomotor pathway to the parotid gland here. So basically this question here is that the child has a tonsillitis and the pain is referred to the ear. Which of the following nerve is responsible for it? So guys, answer to this question is a tympanic branch of glossopharyngeal nerve, or you can say the Jacobson's nerve here. The tympanic branch of glossopharyngeal nerve or Jacobson's nerve. Now this nerve, the what do you say, the general sensation, the sensation from the palatine tonsil is carried by the ninth nerve, and also the ninth nerve is supplying the ear as well. It is, the tympanic branch of glossopharyngeal nerve. It goes into the middle ear cavity, it forms a tympanic plexus, then eventually it gives the lesser petrosal nerve, which is a basically secretomotor pathway to the parotid gland here. So tympanic branch of the ninth nerve is the answer to this question number 6, which is responsible for the referred pain of the tonsil to the ear. Question number 7, guys. Question number 7 says the patient presented with the swelling. Now again, I cannot be sure that where exactly the swelling was shown, but the people said that the swelling was shown. There was 2 different questions. I have another question after this. They said there's a question asked in which they showed the swelling just below the ear lobule. Actually, it was just below the ear lobule here. And the question said something like this: the patient presented with the swelling and pain in the area as shown in the image. Now, which nerve is responsible for carrying the pain from this affected area, guys? I hope you know that the lobule of the ear, completely, the lobule of the ear and the skin at the angle of mandible and the lower parotid area, guys. This entire area is the area for the great auricular nerve. There is an area for the great auricular nerve here. Now, this is again something which I emphasize very much in the class also, that in the posterior triangle of the neck, one nerve which is present in the roof, that is great auricular nerve, and the nerve which is present as a content, that is spinal accessory nerve, is the most important and the most frequently asked question from there here. And if you look back, you look at the history of this great auricular nerve. Now this year it again added like more to it here. The great auricular nerve, as the name says, great auricular nerve, this is something which is being asked over and over and over again here. The question about the nerve supplying the lobule of the ear, the question about the nerve supplying the skin at the angle of mandible, the question about that which nerve runs with the external jugular vein, that's the same nerve which runs with the external jugular vein coming from C2 and C3, one of the branch from the cervical plexus. So like there are multiple questions asked for this. Like there was a question that after the parotid surgery, the patient felt a sensory loss while shaving. And so which nerve basically got injured in that case? The answer was again great auricular nerve. And yet again they asked the question on the great auricular nerve, but this time the question was a little different. They showed a swelling present below the lobule of the ear, and the question was that which nerve will carry the sensation, pain sensation from there? Answer, it has to be the great auricular nerve. The great auricular nerve. So these are like, as I said, I'm sure that when you look at these questions, this is what makes the previous year questions very important, because when you look at the previous year questions and you find out that there's a particular question asked, because if you look at from the question point of view, then you may see as a different information. Which nerves with the external jugular vein? Sounds like a different question. Which nerve supplies the lobule of the ear? Different question. Which nerves the sensation lost after the parotid surgery? It sounds like a different question here. But every time the answer is what? Great auricular nerve. So basically the examiner is picking up the great auricular nerve and introducing it into the different clinical scenarios and asking this question over and over again. So it's our responsibility to know about this, in and out about this nerve. So the next time they ask me anything related to this nerve, there should not be any confusion in that. Chali guys, moving on to the next one. The next question which said here, now this is a question which basically created a little stir. It says a patient came with a painful, slowly progressive swelling of the parotid gland as shown in this image here. Now, what is the anatomical basis of the pain in this region here? Now, for me, in this question, the anatomical basis word is very important here. And I've confirmed this with many people. I've confirmed with the faculties who even went for the examiner that anatomical basis of the pain of this region was specifically mentioned in this question here. And this is again something which we discuss in our regular classes also, that see, deep fascia is present almost everywhere except at few places. Like there is no deep fascia present on the anterior abdominal wall. We have Camper's fascia, we have Scarpa's fascia. There is no deep fascia present on the face. Muscle of facial expression, they originate from the bone and they insert on the skin. You need to have a facial expression. How will you have a facial expression? When the skin will get wrinkled. That's a facial expression, right? So all the muscle of facial expression can produce the expression because they're inserted on the skin. That's why there is no scope of having a deep fascia on the face except for the parotid gland. Now the parotid gland, this parotid gland is the area which is, parotid gland is covered in the deep fascia, and that is called as a parotidomesenteric fascia. It is an extension of the investing layer of deep cervical fascia. And it's the unyielding nature of the parotid fascia, or you can say parotidomesenteric fascia, which basically makes the mumps very painful here. We know all that mumps in children are really painful here. And the reason is because this fascia is very unyielding here. Now, the same kind of concept we read in the ischiorectal fossa also, guys. Like in ischiorectal fossa, if you have the perianal space, where there is no space over there, because there is no space, that the fat is tightly packed over there. So any infection of the perianal space is extremely painful because there is no space for the infection to spread, and that will irritate the nerves here. The same concept is in here. Now, I want to quote a statement from the Gray's 41st edition, which says that unyielding parotid capsule derived from the investing layer of deep cervical fascia. So acute inflammation of the parotid gland may cause exquisite pain, okay, in the preauricular region as a result of the stretching of the capsule and the stimulation of the great auricular nerve. Although great auricular nerve, as per the feedback, is also in the question here. But see, the anatomical basis, the basis of the pain is because of the unyielding nature of the parotid capsule here. And that parotid capsule is made up of investing layer of deep cervical fascia. So yes, this great auricular nerve can confuse you in this question here, but because if it says the anatomical basis for the pain, so my answer here has to be the investing layer of deep cervical fascia. Investing layer of deep cervical fascia. It's not about which nerve is carrying the pain, it's the anatomical basis for the pain in this area. And the answer is investing layer of deep cervical fascia. Moving on to the next question, guys. Question number 8. Question number 9. Now, question number 9 says, after sustaining a stab injury, a particle got stuck in the lateral aspect of the dorsal cord in the neck region. Which of the following loss is most likely seen here? So like there is the stab wound injury, which is in the neck region here. And the question has specified that it got stuck in the lateral aspect of the dorsal part of the cord. Lateral aspect of the dorsal part of the cord. So what is most likely to be seen in this case here? Now, before we go to the options here, let's have a look at this picture here. Now, in this image, what you see here, these are the dorsal horn. This is the ventral horn, right? That's the dorsal funiculus. That's a lateral funiculus here. That's an anterior funiculus. Now, if I go to the dorsal side, because the question is specifically about the dorsal side, guys. Now, on the dorsal side, you know the dorsal column tract is present. And in the dorsal column tract, this area here, which is like medially, this is called as a fasciculus gracilis area. And more laterally here, it is a fasciculus cuneatus. The fasciculus gracilis and fasciculus cuneatus. Now, you all know that fasciculus gracilis is basically carrying the sensation from the lower limb. And fasciculus cuneatus is carrying the sensation from the upper limb. The upper limb. And what sensation? Well, it is carrying the conscious proprioception, fine touch, vibration, stereognosis, some amount of pressure also. Like all these sensations are carried by the dorsal column tract here. Now, we all know that one property of the dorsal column tract is the dorsal column tract, it decussates in the medulla oblongata and not in the spinal cord. So once the information enters inside through the dorsal root ganglia and goes inside, it goes directly into the white matter and forms the fasciculus cuneatus, and the one which are coming from the lower limb, they will form the fasciculus gracilis here. And once they reach the medulla oblongata, they will relay into the nucleus called as nucleus gracilis and nucleus cuneatus. And after that, in the medulla oblongata, that's the area of the medulla oblongata. After that, in the medulla oblongata, they will decussate and they will form the medial lemniscus and will reach the thalamus and ultimately to the cortex here. So my point here is that decussation of the tract basically takes place in the medulla itself here. And after that, they are forming the lemniscus here. Now, in this question, it is very specifically mentioned that the particle got stuck, or the injury basically is toward the lateral side of the dorsal column tract here. And if it is toward the lateral side of the dorsal column tract, the fasciculus cuneatus will get affected here. Fasciculus cuneatus, as we already said, is carrying the sensation from the upper limb. So there will be proprioceptive loss from the upper limb. Will it be ipsilateral or contralateral? Well, it will be ipsilateral because the tract is going to decussate in the medulla oblongata. Had it been this injury in the pons or in the midbrain here to the lemniscus, then you would have said that it is from the contralateral side. So injury is in the spinal cord and it is carrying the sensation from the same side only. So the answer to this question has to be the proprioceptive loss, ipsilateral proprioceptive loss of the upper limb or arm. So proprioception in the ipsilateral arm will be lost here if there is a dorsal column tract injury, and that too toward the lateral side. Now again, no, you don't have to know anything special for these kind of questions here. Now, again, this is during the class, which I always say that when you're looking at the tracts here, now some people, they just write the name of the tract and they just mug it up. Okay, the dorsal column tract function is this, the spinal thalamic tract function is this here. Now you need to look at the pictures for them here. Even if it is a very schematic line diagram image, you need to look at those images here so that you kind of register in your mind that where exactly these tracts are located. Now, I remember, although it's a very, very old question, there was a question about that if the lateral sectioning of the spinal cord is done, then what is the sequence of the sensory modalities to be lost here? Now, that's a kind of question, it's not a clinical question here, because it doesn't, this question doesn't make a sense, because there will be a motor loss also, there will be sensory loss also. But the examiner specifically wanted to know that what sensory losses will be there and what sequence the sensory tract will be lost if you do the lateral sectioning of the spinal cord here. Right? So it is just to check whether or not you know that where these tracts are located. So if you know the dorsal column tract is function is this and this, you should know that what are the two parts of dorsal column tract here. And this basically the question boils down to the common sense only. Dorsal column tract में injury हुआ है, lateral side की तरफ injury हुआ है, तो fasciculus cunatus will be affected. So whatever loss will be there, it is in the upper limb here. Dorsal column tract will decussate in the medulla oblongata. So any injury in the spinal cord, the effect has to be the ipsilateral, right? So that again, these are a very, very basic questions. When you look at from the clinical format, it looks like that, okay, they're asking a question in which there is a stab wound injury and it is the question is very specific about the lateral part of the dorsal side of the spinal cord. But बहुत simple questions, guys. I mean, if the people who use a little common sense and if they know a little about these dorsal column tract, I don't think anyone got this question wrong. Okay, now moving on to the question which many of you actually got wrong, and that is this question number 10. A 50-year-old patient presented with the 50-year-old patient presented with a history of fall 1 week back, presented with a headache, dizziness, and ataxia. Given the history of the chronic alcoholism, last alcohol consumption was 2 weeks back. This non-contrast CT finding was given below, and the question was asked about the diagnosis. Now, when you look at this picture here, I know that the first impression, even when this picture was sent to me in the feedback, in the recall, the first impression this picture gives is the EDH, that idli shaped thing, right? That's EDH here. But that's not the case of EDH. And the first and the biggest hint is not in the picture, it's actually in the case itself here. It says, with a history of fall 1 week back. It's not an acute history. Had it been an acute history, guys, this could be the case of the arterial bleed. It could be EDH here. But this is of the patient will not come after 1 week. It's a history of fall 1 week back. Presented with a headache and dizziness and ataxia here. So that's why, first of all, that's the reason that the EDH is out of the picture here. Now, before we go to the answer here, it's a very basic discussion. Everyone knows about it. Now, I just still want to discuss it very quickly in there. Now, the two types of bleed which kind of confuses you here, that is epidural hematoma and the subdural hematoma, guys. Now, you know what is epidural and subdural hematoma? Epidural hematoma is basically that extradural. It's outside the dura mater, inside the bony table, but outside the dura mater here. And when we say subdural hematoma, it is basically due to the dura mater. Now, epidural hematoma, it's an arterial bleed, especially the anterior division of middle meningeal artery. That's the usual artery involved in this extradural or epidural hemorrhage. And the subdural hemorrhage is because of involvement of the bridging veins. The rupture of the bridging veins, the tearing of the bridging veins can lead to that here. Okay, so epidural hematoma, the thing is, epidural hematoma, it is basically limited by the sutures. So that's why when you see this convex shape of this epidural hematoma, it is limited. It is smaller in size because it is limited by the sutures. But that is not the case with the subdural hematoma. It is more like the crescentric shape, and you will say it's more expanding here because it is deep to the dura mater. So obviously the sutures cannot limit it. If you look at these two pictures here, just a comparison here. If you look at that first picture here, over there is a subdural hematoma here. You can see it is more crescentric shape and it is like more expanded, and you have a more focal bleeding over there. And you can see it is because it is limited by the suture here. That is a case of extradural hemorrhage. But when you look at this picture, if I take you back to the image which is given in the question here, as I said, the first impression it gives off, if you look at the shape and all, it may give you the impression of the extradural hemorrhage. But this is not, because this says there is a history of the fall 1 week back. And that is the reason that answer to this question is not extradural, it is the subdural hematoma. The answer to this question is A, that is a subdural hematoma. I know many people would have answered this question as extradural, but the answer is subdural hematoma. Moving on to the next question, guys. Next question, but pretty simple one. Question number 11, it says that injury at which of the following site will impair the dorsiflexion of the foot here. The injury of which of the following now will impair the dorsiflexion of the foot here. Now, first of all, before we go to the options and everything in this question here, just understand that the leg is having three compartments. Leg is having three compartments. The anterior compartment of the leg. There we got the posterior compartment, the calf muscle, the posterior compartment. And then we have the lateral compartment in the leg here. Now, unlike thigh, where we have an anterior compartment, posterior, and the medial compartment, leg is having anterior, posterior, and the lateral compartment. Anterior compartment muscles are the dorsiflexors. The dorsiflexors. Posterior compartment muscles are the plantar flexors. Are the plantar flexors. And the lateral compartment muscles are everters. Lateral compartment muscles are everters. Any injury to this dorsiflexor compartment here, we know that one very common thing, that is the foot drop. Foot drop is the common condition which is seen in case of the dorsiflexors, if the dorsiflexor muscles are involved here. Now, the question here is like this only, that injury at which of the following site will impair the dorsiflexors of the foot. So basically for that, there should be the involvement of the muscles of the anterior compartment of the leg here. Now, if you look at the pointed areas in this here, one of the arrow, as per the feedback, was pointed at the lower end of the femur. One of the arrow was at the upper end of the tibia. One was at the head of the fibula, and one was at the neck of the fibula. Now, I hope you all know that the sciatic nerve, once the sciatic nerve, you will see will running in the popliteal fossa, and will divide into the one branch that is a tibial nerve, which will be running posteriorly, and then it will give off a common peroneal nerve, and this common peroneal nerve will wind around the neck of the fibula and divides into two branches. One is a superficial peroneal nerve, the superficial peroneal nerve, which is going to supply the lateral compartment, and the deep peroneal nerve, which is going to supply the anterior compartment here. This is the nerve which is going to supply the anterior compartment, the dorsiflexors. So the injury to the point C, that is a neck of fibula, injury at the neck of fibula, that's a very, very common question. Like last NEET, INICT also, they gave the picture of the fibula and they pointed the arrow at the neck of the fibula, and the question was that which nerve can get injured at this point here. That was a common peroneal nerve. So injury to common peroneal nerve, obviously, which is present in close relation to the neck of fibula, will impair the deep peroneal nerve and superficial peroneal nerve. And we know that deep peroneal nerve supplies what? It supplies the dorsiflexors, all those muscles like extensor hallucis longus, extensor digitorum longus. The names are not important, the functions are important, and function is dorsiflexor. So the dorsiflexors will be involved, and there will be foot drop. Now, again, a little tricky part of this question was, which I hope that you'll concur this. When I asked like my fellow faculties who went for the exam, they said that one thing that they did in this question is that because this question was pretty simple, they know that everyone will be marking, most of the people will be marking this, the neck of fibula only. So what they did when they gave the option A, B, C and D, they changed this, they did not give A, B, C like this here. Can you see that sequence over there? They kind of reshuffled the sequence here, because if you look at this point C, some people will just go and directly mark this option C here. This is just basically a mental game only, nothing else. It's not testing your knowledge, it is just testing that how like mentally present you are in the exam here. So the point C is basically corresponding to the neck of fibula, but guys, point C over there is option B, as per like what MCQ I got in here. So this was a little trick they played there, that ABCD, generally when we frame the questions with you, now what we do is ABCD, and the options are also ABCD here. Now we'll also keep it in mind that when we frame the questions for you in your grand test and other questions, we'll also try to reshuffle these options, because you need to have this practice in your head, that look at this option C over there is represented by the option B over there, and that's the answer to this question here. So some people got it wrong because of the concept, very few people, and I think some people actually got it wrong just because of they saw the C and they marked the C, and option C was not the C actually. Moving on, guys, next question here. The next question here is about a man has numbness over the volar aspect, that is the palmar aspect, of the radial 3.5 fingers. The moment you say radial 3.5 fingers on the palmar aspect, I know that everyone knows which nerve comes to the mind here. It says which get relieved when he hangs hand from the bedside. Which site and test is most likely the answer to this question here? Now, first, please understand, the moment you say the volar aspect and that to the lateral 3.5, then obviously ulnar nerve is not the answer to this question. Ulnar nerve is all about medial 1.5 on the volar aspect as well as dorsal aspect here. So it is all about the median nerve. And by looking at this, obviously the option C and D completely goes out of the equation here. Guyon's canal is a canal which is present deep to the pisohamate ligament, and it is giving passage to what nerve? Ulnar nerve. Guyon's canal syndrome, ulnar nerve is involved in that way. So guys, Guyon's canal cannot be the answer to this question. The answer has to be related to the median nerve. So it is either option A or it is option B. Before we go to that actual answer to this question here, just have a look at this, guys. If you look at this image here, all this highlighted area is showing you the innervating region of the median nerve. As you can see, the median nerve, palmar cutaneous branch supplies the skin of the palm. The digital branch supplies the volar aspect. That was the question, the volar aspect of 3.5 fingers here. And also it supplies the skin of the this area of the nail bed area also. Wherever the radial nerve is supplying on the dorsal aspect, the nail beds are supplied by the median nerve here, right? So median nerve obviously is the one which is involved in this case here. Now the two tests which are mentioned in there, one is the Durkin's test and the Froment's test here. Have a look at this image, guys. Now Durkin's test, now this Durkin's test is basically a little more modification, or you can say advancements for the Froment, the Tinel sign only. Now what we do in the Durkin's test, as you can see in the picture here, the therapist will put the fingers, both the thumb, on the distal part of the flexor retinaculum, because it's a carpal tunnel over there, and we'll press it hard here. If you have a tingling sensation in the lateral 3.5 finger, then that is a positive Durkin sign, and that's positive Durkin sign is obviously for the median nerve. That is for the median nerve, because you're compressing the area over the carpal the carpal tunnel. That is basically the flexor retinaculum is there, and you're compressing the median nerve in that case here. Whereas in other case, because this was also given in the option, just to go with that, this is nothing but the Froment's test or Froment's sign. Now what is there in the Froment's test here? If you ask the patient to hold a piece of paper or card in between the index finger and the thumb, that the usual way of holding this is in this manner here. Why? Adductor pollicis, guys. There is muscle, one of the muscle of the thumb, the adductor pollicis muscle, which is coming from the shaft of third metacarpal, I'm sorry. That adductor pollicis muscle will pull the thumb toward the rest of the fingers here, and that muscle, adductor pollicis, is the last muscle to be supplied by the ulnar nerve. Is one of the muscles supplied by the ulnar nerve. It is basically the last muscle to be supplied by the ulnar nerve. So if your adductor pollicis is working, that means your ulnar nerve is working, then Froment sign is negative. That means you will hold the paper like this. The normal way of holding the paper is by basically just trying to pinch the paper between the index finger and the thumb. But let's say if your adductor pollicis is not working, then what are you going to do? If you still have to hold this paper in between the thumb and this index finger, then instead of using the adductor pollicis muscle, which is, you can't do it if the ulnar nerve is not working here, then you will use some other muscle here. And what that other muscle is, now that's a muscle which is coming from the forearm, and it is inserted on the distal phalanx, and that muscle is flexor pollicis longus. Flexor pollicis longus is supplied by the anterior interosseous nerve, and anterior interosseous nerve, we all know, is a branch of median nerve. So guys, if you're not able to hold the piece of paper like this, then you will basically flex your interphalangeal joint of thumb by using which muscle? Flexor pollicis longus, and then that's a trick movement you will do to hold that piece of paper in between the thumb and the index finger, and that is a positive Froment sign. That means your ulnar nerve is not working, because adductor pollicis is not working in that case, and that's why you're doing the trick movement by using which muscle? Flexor pollicis longus, which is supplied by the median nerve. Since our question clearly mentions about the sensory loss or on the volar aspect of the 3.5 side of the finger here, so it's obviously about the median nerve. So carpal tunnel and Durkin's test. We know that Durkin's test is a test which is done for the median nerve. So answer is option A here. Froment sign is done for the ulnar nerve. Durkin's test is done for the median nerve. So carpal tunnel is obviously because median nerve is involved here, and Durkin's test is a test which is done, which is, as I said, the modified Tinel's test only, or Tinel sign only. That is Durkin's test, which is done for the median nerve. So these kind of mix and match questions are also very common nowadays. Like when they give you a particular question here, and they will give multiple options, like this is one of the way, or they like sometimes the question, like they will say option A is correct, or option A and B both are correct, or B and C is correct here. which is basically what PGI used to do. They used to have 5 options when we used to have this PGI exam. Now we have a question, and we used to have multiple answers to those questions. Now we have to choose one single best answer. So sometimes they don't complicate the question, they complicate the options. The questions is pretty simple here. The moment you look at the volar aspect of the radial 3.5 finger, that you know it's median nerve here. But you also need to know that which is a site for the median nerve and what is a test done for the median nerve, and that's where the options are testing you for it. Okay, moving on to the next question, guys. Question number 13. Question number 13, well, again, this question is also which many people got it wrong here. When again, I'm just discussing this question based on the feedback here, because still a lot of people believe that this was not the slide, it was a slide of pancreas, although this is a slide of a kidney. Now, had it been the slide of a pancreas, guys, now this pancreas we discussed in the one shot video also, guys, if this is a slide of pancreas, then you will see this lightly stained zone in between, that is basically the islet of Langerhans. But for that, just don't look at the islet of Langerhans. You also need to look at the surrounding area also. You can see the serous acinus present over there. Even if you cannot appreciate the centroacinar cells and all, you can still make out that you cannot see any lumen in there. They are obviously, this is definitely not the slide of a kidney. It is a slide of a pancreas. If you look at this slide over there, if you look at this slide in this region here, now here are the Bowman's capsule. All these areas which are indicated in the image, that is a Bowman's capsule. And I can clearly see the parietal layer, and I can see the visceral layer, and the visible gap also is seen in between, guys. The parietal layer and visceral layer are clearly seen, and the clear gap is seen in between here. You can even see this, the PCTs and DCTs inside here. The one which is having a hazy lumen over there is a PCT. The one with the clear lumen inside, these are the DCTs over there. So the PCT, DCTs were also, you can easily identify them. And based on that, based on the feedback, again, I would say that this question which they gave in the exam was a slide of a kidney and was not of the pancreas here. So this kidney, pancreas, parotid, these are the slides which are like kind of look-alike slides, and you need to kind of differentiate them here. In fact, this is what my plan is, that I'll be conducting a series where, because what I see that in the recent time, they're asking the questions simply on the identification. In the last 3-4 years, if you pick up any question, you will see the question is just about identification. Last NEET, there was a question on the fibrocartilage. There's a question on the cerebellar cortex. There's a question on, or like you can see this question asked on this Bowman's capsule of the kidney. So nothing detailed they're asking here, but yes, the basic identification of slide is very important. And obviously, if they have to go with the same kind of questions where they will only be asking this identification of basic slides, so they obviously will try to give the slides which are easily confused with another one here. So we need to have the understanding of the slides which look alike here, which is I'm going to do in a future series on my channel. So guys, yes, for this question, as per the feedback, the answer has to be the glomerulus of the kidney, and it's not the islet of Langerhans. Okay, moving on to this question, although again, as per the feedback, the people said that in this question, it was a hand-drawn image. It was a hand-drawn image, and the arrow was placed here. It was a vertical arrow which was placed here. Now, there were 2 openings which were shown on more toward the lateral side, one toward the medial side, above the inguinal ligament. So obviously, the one toward the lateral side, that is a deep inguinal ring. There is a deep inguinal ring. And this here is the superficial inguinal ring. Now, deep inguinal ring is an opening present in the fascia transversalis. And superficial inguinal ring is a defect of the opening present in the external oblique aponeurosis. Is an opening present in external oblique aponeurosis. Since the question was on the deep inguinal ring, it was marked on the deep inguinal ring. So the answer to this simple question has to be the fascia transversalis or the transversalis abdomen, the fascia transversalis, sorry. The fascia transversalis. Now, there was another question, a related question only here, but before I go to that, I want to show you the picture where you can see the superficial inguinal ring, deep inguinal ring, the inguinal canal also, and I want you to understand the boundaries of the inguinal canal, because another question which was asked in the exam was based on that only. Have a look at this image, guys. If you look at this picture here, no, let me just go with an orientation here. First of all, the muscle that you see outside here, that is an external oblique muscle. This muscle here is external oblique. So this obviously is the external oblique aponeurosis. And what you see, the external oblique aponeurosis also contributes to the inguinal ligament here. The lower part of the external oblique aponeurosis, it upturns, and that forms the inguinal ligament as well. And you can see this defect or this opening present in the external oblique aponeurosis here. This is nothing but the superficial inguinal ring. That's a superficial inguinal ring. Then we have internal oblique muscle, the transverse abdominis muscle. I hope you can see that's internal oblique. The next one here is a transverse abdominis. And then we have this fascia transversalis. And if I again go with that, if you look at this fascia transversalis, come in there, and that's the opening over there. That's the opening of the fascia transversalis, and that is nothing but the deep inguinal ring. So first and foremost, the deep inguinal ring is an opening present in fascia transversalis, whereas the superficial inguinal ring is an opening present in external oblique aponeurosis. To be more precise, I would say external oblique aponeurosis. So obviously, extending from this deep inguinal ring to the superficial inguinal ring is the inguinal canal, right? That's the inguinal canal. If I enlarge this a little further for you, now what you see, that is the inguinal canal over there. Guys, what you see, that this internal oblique muscle and transverse abdominis muscle, they will arch above the inguinal. So they are basically forming the roof of the inguinal canal. You can see the arching fiber of internal oblique, that's the arching fiber of internal oblique. And this here is the arching fiber of transverse abdominis. And they both are contributing to the roof of the inguinal canal, roof. Once this internal oblique muscle and transverse abdominis muscle reaches backward behind the inguinal canal, they together forms this tendon, and that tendon here is called as a conjoint tendon. That is called as a conjoint tendon. So remember one thing, that conjoint tendon clearly is contributing to the posterior wall of the inguinal canal, guys. It is contributing to the posterior wall of inguinal canal. You can see that's a conjoint tendon there, and that is contributing to the posterior wall of inguinal canal. Now, the question about the direct hernia and the indirect hernia. Had it been the case of the indirect hernia, that obviously it will enter through the deep inguinal ring, will go through the inguinal canal, and will come out of the superficial inguinal ring here. But if it is a case of the direct hernia, which is medial to the inferior epigastric artery or above the pubic tubercle, in that case, the conjoint tendon weakness can lead to that here. The intestinal content will still be able to herniate through this opening because conjoint tendon weakness is there. So they will push along with this conjoint tendon, and the intestinal content will be herniated into this, coming out of this superficial inguinal ring, causing the inguinal hernia. Now that's exactly was the question asked as per the feedback here. It says that which of the following weakness can cause hernia medial to inferior epigastric artery and above the pubic tubercle, guys? If it is above the pubic tubercle and medial to the inferior epigastric artery, so obviously we're talking about the direct hernia. And for the direct hernia, we need to see that the intestinal content are basically pushing the posterior wall of the inguinal canal, and the posterior wall of inguinal canal is formed by the conjoint tendon. That is by the conjoint tendon. Lacunar ligament is the modification of the inguinal ligament only, which is present in the floor of the inguinal canal. Pectineal ligament is also one of the modification of inguinal ligament only, and reflected part of inguinal ligament is also present in the posterior wall, but that is very close to the midline, very close to the midline. I'm not very sure about the other options here, but the conjoint tendon definitely was given in the option, and that is the answer to this question. You can see this picture here. This is again another picture to the same thing only. If you look at this, here is the direct hernia shown in there. Now, that's an inferior epigastric artery that is shown by this here. And if you see in this case here, you can see the external oblique over there. First of all, external oblique. Then you see the internal oblique and transverse abdominis muscle, and they're together forming this conjoint tendon. That is the conjoint tendon to be shown over there. Then we have obviously the fascia transversalis and the parietal peritoneum. That's a parietal peritoneum here. And you can see the intestinal content, when it is causing the direct hernia, it is pushing through the conjoint tendon. The weakness of the conjoint tendon, basically you can, or in other words, you can say it's a weakness of the internal oblique and transverse abdominis muscle, which could be the reason for this direct hernia, and that's why it is pushed along with the intestinal content into the inguinal canal. Well, quickly moving on to the next question, guys. Question number 16. The question number 16 says, a 45-year-old male underwent laparoscopic hernia for bilateral inguinal hernia with mesh entrapment. Post-operative, he complains of pain for 3 months in the right lower limb. Sorry, that's not right. That's right lower limb. Which nerve got stuck in the fixator would lead to this complication here? Now see, in this laparoscopic hernia repair, there are like multiple nerves which can get gnawed here. If we go with the surgical text here, they say that the most common nerve which is to be involved in this laparoscopic hernia repair is the lateral cutaneous nerve of thigh. Now I'll tell you that one rift in this question is that some people said that in the question they mentioned there is a pain in the right lower limb, and some people said it was leg which is specifically mentioned here. So this, I don't know whether it was lower limb or it is leg, but once again, if I go with the feedback which is coming from the faculties who went for the exam itself here, now Dr. Rajat, he himself told me that he clearly remember that lower limb was mentioned in the question here. If I go with his words, which I will, he said the lower limb was mentioned. If the lower limb was mentioned here, then the answer is different here. But if the leg is mentioned, then the answer is different here. Now, first of all, look at this thing, guys. You all know that there are, like I discussed this in the one shot revision series also. We discussed all these nerves present on the posterior wall. You can see all these nerves basically are coming from the lumbar plexus. There is the iliohypogastric and ilioinguinal nerve coming from L1. This nerve can also get, though rarely, but it can get also involved in this laparoscopic hernia surgeries. Genitofemoral nerve, which will divide into genital branch and femoral branch, lateral cutaneous nerve of thigh, and the femoral nerve. Now, we already discussed in the one-shot video that how to identify these nerves, how they're present, what is the relation with the psoas major muscle, and how to identify these nerves, right? Now, the question here is about that there is a pain which is in the lower limb. Now, for that, if a femoral nerve is involved, let's say, then obviously there are cutaneous branches of femoral nerve supplying the thigh also, and there's a femoral branch, or there is a saphenous branch of the femoral nerve which is supplying the medial side of leg. So if the question was actually having a leg written over there, then obviously no doubt the answer has to be the femoral nerve. But as I said, as per the feedback from the faculties, they said it was lower limb which was mentioned and not the leg. In that case, the answer has to be the lateral cutaneous nerve of the thigh. Now, look at this couple of this few texts which I have just collected for you. It's a text which is given in the surgery books here. Now, it says that if I go with the lateral cutaneous nerve of thigh here, guys, lateral cutaneous nerve of thigh, it says this is the most lateral nerve in the growing region here, the most common nerve irritated during the laparoscopic repair. So, obviously, when they're asking the question, my first thought will go toward the nerve which is most commonly involved in this laparoscopic repair here. That is a lateral femoral cutaneous nerve, or you can say lateral cutaneous nerve of thigh. If irritated, there may be pain or hypersensitivity along the lateral thigh here. We all know about the meralgia paresthetica also, guys. We've discussed that in the classes as well. If the genitofemoral nerve, if it is usually perceived by the hypersensitive in the scrotal region here, and if the genitofemoral nerve is involved, then there will be the sensory involvement in the area of the femoral triangle. You know, the roof of the femoral triangle is supplied by the femoral branch of genitofemoral nerve, which was again the INICT question here. The question about the femoral cannulation, that which nerve need to be anesthetized, and that was the femoral branch of genitofemoral nerve, right? Femoral nerve, as we said, if the femoral nerve is irritated, which is not a very, let's again say rather rarely, then in that case, obviously the nerve can go along the leg as well, because saphenous nerve is a branch of the femoral nerve which is supplying the skin of the leg region. So if the leg was mentioned in the question, let's go with both the thoughts here. Let's say if the next time this question is asked and if they give you specifically leg in the option, go with the femoral nerve, no doubt about that here. But if the question simply says that pain radiates to the lower limb, then I have to go with the nerve which is most commonly involved here, and that is the lateral cutaneous nerve of thigh. Ilioinguinal nerve and iliohypogastric nerve, they are involved in this laparoscopic repair, but as I said, it's extremely rare. It's extremely rare, and it says extraordinarily rare involvement of the iliohypogastric nerve and ilioinguinal nerve. So that's why my question here, for my answer here to this question is the lateral cutaneous nerve of the thigh. Lateral cutaneous nerve of the thigh. But as I said, it's not about that what is the right answer to this question. It's simply that there are two different questions, guys. इसी क्वेश्चन के अंदर लोअर लिम्ब की जगह लेग मेंशन्ड है, go with femoral nerve. If simply lower limb is mentioned, go with the lateral cutaneous nerve of thigh. Simple. Which brings me to my last question here, and that question is about question number 17. Says that patient has a history of the liver cirrhosis. Which of the following vein forms the anastomose in case of portal hypertension? Obviously, when there is a liver cirrhosis or there is any obstruction in the portal vein, there will be portal hypertension, and because of the portal hypertension, the site where the portal the tributaries of the portal veins and the tributary systemic veins, they're anastomosing, they will get engorged. So what do you see? First of all, let me put this picture to you to show you some of the common site for the portosystemic anastomosis. Guys, portosystemic anastomosis take place at many regions here. But in this image, first of all, look at this portal vein here. This here is a portal vein. That's a portal vein there. And all these are the tributaries of portal vein. You can say the splenic vein is there. There's a superior mesenteric vein, right? All these are the tributaries of the portal vein. The left gastric, right gastric, all these are portal vein here. So the one which is shown in the purple color there, that is basically the portal. And the one which is shown in the blue color here, there's a systemic vein, the inferior vena cava. One of the site for the portosystemic or the portocaval anastomosis is the lower end of the esophagus, where you can see the esophageal branches of the left gastric vein. Guys, left gastric vein is a branch of the portal vein. Is anastomosing with the esophageal branches of the azygous and hemiazygous vein. The lower end of the esophagus, the venous drainage goes into the azygous and hemiazygous vein specifically here, and that becomes the site of portosystemic anastomosis. So when there is a portal hypertension, there is a backflow here. Then obviously when there is a backflow, the portal vein blood is trying to find the way to reach the systemic circulation, and they will engorge this area here and causes this esophageal varices. Another, I'm talking about the more visible site here, because some people said in the question it was like written as that what is a visible site or the most visible site for this portosystemic anastomosis. One is the anterior abdominal wall. Now what you see in the anterior abdominal wall, we have some superficial veins of the anterior abdominal wall. Again, they are the which belongs to the systemic circulation, and we have the paraumbilical vein. And you can see the paraumbilical vein again is a part of portal system here. So this again becomes a part of portocaval anastomosis here. And that's why in case of portal hypertension, there will be engorgement of these veins in this area, leading to the caput medusae. And we also do have another very important site for the portosystemic anastomosis, and that is when the superior rectal vein, which is again a part of the portal system. Now, why it is a part of portal system? Because superior rectal vein, it drains into the inferior mesenteric vein, and inferior mesenteric goes into the splenic, and splenic is one of the formative of the portal vein here. So that's a part of the portal system. Whereas the middle rectal vein and inferior rectal vein, the middle rectal vein is coming from the internal iliac, inferior rectal vein is basically draining into the internal pudendal. They are the part of systemic veins. So that's again is a site of the portosystemic anastomosis. Again, in case of portal hypertension, there will be engorgement of these veins in this region here, leading to the hemorrhoids here. Right. So once again, just to put the same thing in the tabular form, I'm only talking about the major areas of the portosystemic anastomosis. We do have other sites also, like left gastric vein. We said it anastomoses the esophageal veins, drains into the azygous and hemiazygous. That is at the lower end of esophagus. Paraumbilical vein with the superficial vein of anterior abdominal wall. That is at the level of umbilicus and the anterior abdominal wall. And we just saw that superior rectal vein anastomosing the middle and inferior rectal vein, which is a part of systemic circulation here. And engorgement of these veins in portal hypertension lead to the esophageal varices, which is shown in this image here. You can see that's a picture of esophageal varices. The caput medusae, that is anterior abdominal wall. You can see that the caput medusae, guys, that one mythological character you must know about it. That mythological character which was having the head, which is having a snakes all in the head. The hair are basically the snakes only, nothing else. That caput medusae, and the hemorrhoids. So in the portosystemic anastomosis, these are the common site, the common visible site of the engorgement of the veins here. And as per the options which are provided to us, our answer here is option A. That is a left gastric and the esophageal vein. Left gastric vein, part of portal system. Esophageal vein, part of the systemic circulation. So portocaval or portosystemic anastomosis. So it was a very simple question on the portosystemic anastomosis. One, if you know that what are the veins contributing to the portocaval anastomosis, you're able to answer these questions. So guys, this is about the recall of this anatomy part, the 17 questions that we discussed in here. Now, as I said, there are other questions also. As I said, there was a question on the basal ganglia, there's a question on the homonymous hemianopia, and there are like a couple of more questions which we can also include in the anatomy part, but that will be discussed by the other faculties in the ophtha, in the physiology part. So I'm not going into that region. So overall, when I like look at all the 200 questions based on like, which is like this recall thing is available everywhere. So it was like 21 questions which I saw from like in which the anatomy part was really helpful here. And if imagine 21 question, guys, out of 200 is a huge chunk here, and you can understand. And people who attended my class earlier, and I've got a lot of message from you people that those class notes, that whatever we discuss in the class, they help you analyze these options. If not the exact thing exactly, you are able to at least eliminate the options and you reach the right answer here. Right, so this is the recall from my side. If you find anything, if you want to change any question on any option, you can let me know, because this always helps us to teach the future student that what exactly the question was asked, because a small change in the language of question or the small change in the option can change the entire question itself here. But again, the point here is to know that what are the basic topics, how they're asking them, what are the way they are converting these questions into. And if you ask me that what I have noticed in this paper was that the clinical questions were there, but they were not long clinical questions. They were not like wasting your time giving you 10-12 line questions here. 2-3 line clinical questions were there here. And I'm really kind of very happy to see this kind of paper being asked here, because this is basically taking you from this purely from the rote learning to understanding the subject in a more conceptual manner here. Well, you can avail the soft copy of this entire discussion from my Telegram group. My Telegram group is this. You can find out with the name of Anatomy by Dr. Ashwini Kumar, and you can avail the PDF of this discussion from there. So thank you so much for watching. Please do send me your feedbacks. Let me know about the questions. Let me know about the discussion. Your feedbacks are always valuable. So thank you so much, and all the best for the upcoming exam, and all the best to the people who are waiting for the NEET result as well. Thank you so much.